Hello, can you hear us? Hi, Phoebe. We can't hear you.
I don't think you have an audio device selected. Can you hear us, Phoebe?
She got it. She can hear us.
Can you hear us, Phoebe?
Okay, good. Yes, I hear you. You hear me?
Yes, we got it. Thank you. Where is he? I'm getting all these texts.
I went ahead and muted everybody, so if you have any questions, just unmute your microphone and jump in.
And it is noon, so we are going to go ahead and get started. Welcome to Project Echo. This is our cardiology series that we are doing. We are doing heart-to-heart talks with our esteemed pediatric cardiologist, Dr. Rajani Anand. Also with us today, I'm going to let the rest of our panel introduce themselves.
I'm Alex Boley, I'm a pediatric resident.
I'm Christian Cantrell. I'm a fourth-year medical student.
And we have Dr. Malkani sitting over on the edge, who is our pediatric gastroenterologist, who hopefully will be doing a Project Echo series with us soon. We have 5 parts to the Cardiology Pediatric Echo series. And if you all can be thinking now, next month we're going to be talking about congenital heart disease in the newborn. So if you have any cases in mind that you would like to have input from our peds cardiologist, please be thinking about those and submit those once we get the new forms out. Today's case is actually going to be presented by our pediatric resident, Alex, who is a second-year resident, and she's going to be talking to us about an interesting case. Go right ahead. Yes. And Brian will pull up her PowerPoint that she prepared.
Okay, so this is actually a case from the cardiology clinic. So we have a patient who is a 13-year-old female presenting to the clinic for a pre-participation clearance. So the patient has been
We're getting that up. There you go.
She has been participating in sports since she's been little. She hasn't had any symptoms at all. She's been denying chest pain, palpitations, shortness of breath, dizziness, syncope, or any exercise intolerance. Her caregiver is her maternal grandmother, and she denies any history or signs and symptoms of failure to thrive when she was younger, congestive heart failure, acquired heart lesions, or any repeated lower respiratory tract infections when she was younger. So on further questioning, she does have a very significant family history of hypertrophic cardiomyopathy. Starting really in the maternal grandmother who was diagnosed at age 30. She did require ICD placement and alcohol ablation, but she was never genetically tested for a mutation. Of note, our patient's biological mother also had hypertrophic cardiomyopathy and ICD placement. She did pass away, but from an unrelated accident. And then our patient has a maternal aunt that also has cardiomyopathy and ICD placement. And then she has an uncle that is actually unaffected. So our patient had a previous EKG, which was normal, a Holter monitor, which was normal, and an echo, which was normal, and her physical exam was completely benign and normal as well. So the next step that we kind of did was, so we have our asymptomatic patient with a strong family history of hypertrophic cardiomyopathy without any genetic testing and without any clinical signs of hypertrophic cardiomyopathy. So we first found the index case, which was the maternal grandmother with the hypertrophic cardiomyopathy. We went ahead and referred her to genetics, and we made it a strong point that there was no participation for our patient while this workup was being done. So the maternal grandmother was found to have a pathologic variant on genetic testing for the MYBCP3 gene, which is consistent with hypertrophic cardiomyopathy. So we went on to see if this gene was also present in our patient, which it was. So our patient had the pathological variant, which made her genotype positive, but then phenotypically she was negative because she didn't have any clinical signs of this illness. So further evaluation was done with an MRI, which was completely normal. So the big question.
Okay. So the big question is, can she participate in sports? So Brian, if you can get my slides started. So I wanted to bring this case because this is one of the things that comes up in your pre-participation questionnaire. And we always wonder, why are there so many questions about heart-related questions about the family? And this is one of those very, very interesting scenario that brought out this particular case of the most common cause for sudden cardiac death. Again, she's completely asymptomatic, completely normal exam, normal EKG. But to point out here that the family history is such an important part of the pre-participation physical. And we can go through all these questions in more detail as we go along. So I sort of wanted to start with that. And since we didn't have many other cases, let me go back towards sudden cardiac death. Why are these questions? Why do we ask for dysmorphic features, heart murmurs in the questionnaire, and then come back to all those after we figure out what are the cardiac causes for sudden death. So let me sort of start off backwards. I do like a little bit of a definition history to go in a more systematic way. So, oh yes. So basically I wanted to start off by saying sudden cardiac death is a non-traumatic, non-violent, unexpected event resulting from a sudden cardiac arrest. And again, within 6 hours previously, this kid was completely normal. So the earliest documented case back in 490 BC, that's, again, history seems is something that I'm always interested in. This guy, this soldier, ran from Marathon to Athens, 26 miles, and that's why we have marathons of 26 miles, came to Athens to tell them that we won the war and collapsed and died suddenly. So that's supposedly the first sudden cardiac death that's reported. But we have about 1,000 to 7,000 cases of sudden cardiac death in the US. And again, keep this number because we have a population of what, 300 million in the US, of which 10 million athletes are screened, of which we have 1,000 to 7,000 cases of sudden death in a year. That is like finding a needle in the haystack. And this is so many kids. I know we'd like get so frustrated. Okay, a teenager comes in with chest pain, pre-syncope. Oh, it's nothing. Yes, mostly it's nothing, but these are the kids that we are trying to pick out. So why is it more common in males than females? Not that the cardiac causes are more common in males. It's just because of the type of sports that these males are more into than females. So let's sort of go to the, is it not going to the next slide? Or, thank you. Thank you. So a lot of the causes for sudden cardiac death is cardiac in origin. Okay, so but always think of some of the other causes too, and I'm not going to go through all that. But most of the causes for sudden death is cardiac, and either it's going to be a myocardial arrhythmias or myocardial ischemia, tamponade, and aortic rupture. So these are the two main pathophysiological happenings that cause the sudden cardiac death. So either it's the rupture, tamponade, or arrhythmias. Again, this is important as we go through the causes for sudden cardiac death. This is again a distribution curve and basically talks about the causes for sudden death. As you can see in this distribution curve, the most common cause for sudden cardiac death is hypertrophic cardiomyopathy. And again, that's the first thing that we all think about, that we all keep in the back of our mind. And when you think of it, the incidence or prevalence is 1 in 500, which is quite common. And then as you go through this circle, the next one is undetermined left ventricular hypertrophy, which is probably hypertrophic cardiomyopathy. And with our genetic testing, more and more, we are having a definite diagnosis. The second most common, again, I'm not going to go through every one of them, but the second most common is coronary artery anomalies. This is, again, we'll go through this. The kids are completely healthy. When you see them in your offices for sports physical, they have a completely normal exam, completely normal EKG. But when you come to the pre-participation form and you have these questions about, did you have symptoms with exercise, lightheadedness, pallor? This is what we are trying to pick out, which is the second most common cause for sudden cardiac death. And again, when you go through the circle, there are a lot of things: aortic rupture, dilated cardiomyopathy, channelopathies, and a lot of these lesions are genetically inherited. So that's, again, all the arrows that you see, these are all genetically inherited. So genetics in cardiology has taken a really front step here. And all I wanted to sort of point out was, why is it so important that we ask about heart health questions about your family? And this is the reason. So I put it in a little different form just for us to remember it a little bit more. Again, most common causes is your hypertrophic cardiomyopathy. Second most is your congenital coronary artery anomalies. Just to point out a few things: ruptured aortic aneurysm, Marfan's, bicuspid aortic valve. One quick question, one quick thing about myocarditis. If you have a sick kid, if you have a febrile kid, tachycardic kid, just presume they may have some subclinical myocarditis, and please let them rest and do not let them go back to sports, because they are very prone for abnormal ventricular arrhythmia when they are sick. Again, lot of different causes there. And in the rare cause, it may not be very rare. Commotio cordis is one thing that we keep talking about, and some sources do say maybe it's the second most common cause of sudden cardiac death, and seems to be a very popular question in our pediatric board. So just to keep that in mind, and WPW and long QT syndrome. So once again, these are the ones that we are trying to pick out in our athletes, so we can make the appropriate recommendations. And I'm just going to put all this into, oops, okay, let's go back. Oh, am I going back, Brian? It's not. Okay, yes. So once again, I sort of combined all the questions that you see on your pre-participation physical into this one slide. The family history is very important, because most of these kids may look completely normal, healthy, no physical, no cardiac findings. But if they have genetically inherited autosomal dominant lesions, this is very important. That's how we picked up this kid. And there needs to be a lot of collaboration between adult cardiology and pediatric cardiology, because this grandmother who had this diagnosis for so long should have had a genetic test and did not have one. And she, not being my patient, we had to really work through insurance to get her approved to get the testing done. And we'll come back to that case. So family history of any kind of an autosomal dominant lesion, genetic inheritance. Medical history or the personal history of the patient. Again, like I said, coronary artery anomalies, second most common cause. They're completely normal when we see them in the offices, but have symptoms with physical activity. That's the big thing that we are picking up. Examination, of course, it's most important too. We are looking at a lot of different things that will tell you if there is any indication for an underlying cardiac disease or a cardiac defect. Again, dysmorphic features, heart murmurs with Valsalva maneuvers, blood pressure. So these are all the things that we are looking for in our evaluations. So what I wanted to sort of bring out here is, I know we do a lot of different ways of sports physical exams and clearance, like you bus them all to, like we call it our Freedom Hall, which is the athletic center, and you have stations to do it, and it's not possible for us to have a nice, good pre-participation physical and clearance from those examinations. The most effective way is by the primary care physician who has known this kid for the long time. You know the family history, you know the kid, so this is the best way for a sports physical, and usually should be done 4 to 6 weeks before an event, and every couple of years physical, with every year checking into the family history. So once again, PCP is where we get most of our referrals for sports, cardiac evaluation for sports physical. Okay. So any of these questions that you have in your participation form, if it is abnormal, needs to be sent to cardiology for clearance. And the last sentence here is very, very important. It is legally important. If you refer a patient to me for a cardiac evaluation, they cannot go back to practices, they cannot go back to sports, because legally we can be held to be a problem. So till we clear them, they are not supposed to go back to physical activity. So we come back to our case, and our case was a very interesting kid. Again, the modern medicine, how genetics helps us is how it came into our case. So very briefly, what is hypertrophic cardiomyopathy? We all know what it is, and it's a myocardial disarray, ventricular arrhythmias, myocardial ischemia, again with physical activity, genetically inherited disorder. Even though we have multiple mutations, we are trying to find that index case, like the grandmother. So the grandmother had to have her genetic testing done before we could go to our patient. So for me as a pediatric cardiologist, to get the grandmother's insurance to approve it was a big issue, and I had to work with genetics, adult cardiology to get all her information. So what I'm trying to point out here is their examination, these kids' examination can be completely normal, as in our case that we presented. We do say most of the EKGs with hypertrophic cardiomyopathy are abnormal, but this kid was normal because phenotypically she's completely normal. Echo is the gold standard, and this is a typical parasternal long axis. I have labeled the different chambers of the heart. The left ventricle is small. The septum, the wall between the right and the left brain, we don't have a marker pointer, do we? Is thick. So, thank you. Thank you. Thank you. So what I wanted to show you was here, this is the septum. So we measure the septum and compare it to the posterior wall. The left ventricle is smaller than what it should be. I'm mentioning that because I'm going to come to a case in the end. So this is your typical hypertrophic cardiomyopathy. And when you go in, this is the short axis where we have cut the left ventricle, or looking at it, or like looking at the mitral valve and the septum. Once again, you can see how the septum is so much thicker than the posterior wall. So this is the kid who has myocardial ischemia, low cardiac output, arrhythmias during physical activity. So coming back to our case, so we saw her grandmother, we got her insurance to approve for the genetic testing. She had the typical mutation for the hypertrophic cardiomyopathy. A patient's mother was not available to us, so then we had to go to the patient of ours. She's completely asymptomatic, so no insurance was going to let us do any kind of a genetic expensive testing. So we had to write multiple letters. Eventually we got hers approved, we got it done. She has the same mutation, but she is completely normal. So what do we do right now with her? She has the positive genotype, she's phenotype negative. So fortunately, we have a lot of guidelines. I don't know, fortunately or unfortunately, we do have a lot of guidelines that we are supposed to go by. And again, this is a very nice piece of information that we have. All you have to do is Google Bethesda sports guidelines, and these are the guidelines that we get from them. So she can, again, look at the words that they sort of use. It's reasonable for her to participate in all these sports as long as we make sure everything else is normal, including a cardiac MRI. And then we screen her every year with an echo Doppler study. So we know she can get this disease. When is she going to get it? We don't know. She has the genetic predisposition for it, but right now she's completely normal and she is playing soccer. So this was a very, very interesting case, just to bring out how genetics and cardiology sort of combine. And I so love having Dr. Hajipur, who's a geneticist, with me, because we are always having a lot of cases that we help each other with. So if you have any questions, cases that you can think of, please pitch in. It's still good for me to go on for a, yes. So the second most common cause, congenital coronary artery anomalies. So why are these kids completely asymptomatic at rest? Because they have no symptoms. This is the way the normal coronary arteries come, the left and the right, from two sinuses, right? In congenital coronary artery anomaly, the most common type, where the left coronary artery comes from the right. It has an oblique ostia. It goes between the two great arteries. So think about this kid when he's physically active. His stroke volume is up, his heart rate is up, the pulmonary artery, aorta is pumping, and the coronary artery gets compressed between these two great arteries. So these are the kids that pass out. They look pale, lightheadedness with physical activity. But when they come back into our offices, they have a completely normal cardiac exam and a normal cardiac EKG too. So this is our echo pictures. This is the aorta right in the middle. So any kid that comes to my office for sports physical, pre-syncope pallor, we always want to make sure is that the right coronary artery coming off there is the left one coming off there. So this is a really pretty picture that shows we have two coronary arteries, but this is not a very sensitive specific test. So the next step that we have to go is a cardiac MRI. And again, imagine for me to get a cardiac MRI approved by the insurance is again a problem, because these kids are asymptomatic other than some vague symptoms with physical activity. I have a normal exam, normal EKG, normal echo, so insurance doesn't want to approve it. And that's the best gold standard way is a cardiac MRI to rule this out. So the next thing that I want to sort of really bring to everybody's attention is bicuspid aortic valve. It is actually the most common congenital cardiac anomaly, 2 to 4%. So maybe one of us here, we have it, but we don't know about it. But most common congenital heart anomaly. So again, the reason I wanted to bring this was, this can be familial, this can be genetic. The very, very high incidence of bicuspid aortic valve, and remember this word, aortopathy, I'm going to be using that a lot again, in first degree relatives. So that's what I want to sort of drive home to We all know bicuspid aortic valve is associated with stenosis, regurg, coarctation, infective endocarditis. All that has been known ever since what 16th century is when Leonardo da Vinci described bicuspid aortic valve. That's very interesting to know that an artist went and did human anatomy dissections, and he has pictures of bicuspid aortic valve. But my important thing that I want to come here, it is not just the valve that's abnormal, it's the vascular tissue, it's the elastic tissue, it's the connective tissue that makes the aorta dilate, and this is what ruptures with physical activity that causes you sudden cardiac death. Not the aortic stenosis as much, not as much coarctation, but it's there. But this is what we call it as aortopathy. So whenever we have an index case of a kid with bicuspid aortic valve, we screen all first degree relatives. All the siblings are screened, not just listening. It has to be screening by an echo doctor screening. In fact, I have done a lot of echoes on parents, and if I found a bicuspid aortic valve, aortic root dilatation, then I have to tell them, go see your adult cardiologist. So there has to be a lot of back and forth between peds and adult, but hopefully we are trying to get there. So just a couple of quick pictures of the bicuspid aortic valve. This is such a pretty picture of a bicuspid aortic valve. The fusion right here, you can see the fusion between the right and the left. And this is a non-coronary cut. Typically, you should have a Mercedes-Benz sign or a peace sign. So kids love it when I say you have a Mercedes-Benz sign in your heart, kind of a thing. But this is a bicuspid aortic valve, but functioning well. And it is so hard to hear that click. It's like tuduk, tuk, tuduk, tuk. And if you are listening to this kid in a very noisy place, you're not going to hear it. And for me, sometimes, yes, I hear it. Sometimes I don't hear it. So it's a very typical finding, which is the ejection click. So this is the same kid whose aorta, you can see that here, it should be 3 centimeters. His aorta is 5 centimeters. This is about to rupture. He was completely asymptomatic. Yes, he had a click, no murmur, no stenosis, no incompetence. But aortopathy, at this point, if we don't restrict his activity, if any type of a weightlifting exercise is definitely going to make this aorta rupture, and that's a sudden cardiac death for this kid. This kid, again, it's been a long time. He is probably in his late 30s now. He went to Hopkins, got his aorta replaced, and even now he sends me an email. He's doing his PhD postdoc somewhere, but I am glad we saved his life. And again, what I wanted to bring about with the bicuspid aortic valve was a high recurrence in first degree relatives. So all the siblings need to have an echo screening, not just for bicuspid aortic valve, but for aortopathy also. Okay, this is my favorite thing that I go post it in all the kung fu karate places, especially when my kids were playing. So it's like no contact. So this is just some screen images, like second image or every second kind of images. You can see there was a sparring or whatever kind of a competition going on, and one kid hits the other kid on the left side of the chest, and then he falls down to the ground and he is dead. This CPR was unsuccessful. So this is the thing that I have gone and posted in the Kung Fu Karate schools everywhere. So, but anyway, what I wanted to bring about with commotio cordis is that there is no way that we can screen for this. These happen in normal kids. More awareness is what we need. And so this is, again, like I said, 20% of all the athletic field sudden deaths, maybe second most common, more common in the younger kids because their chest is more elastic and pliable. So what is it? It's a concussion of the heart from non-penetrating blunt trauma to the chest. So this is either they can have myocardial trauma, tamponade rupture, or ventricular arrhythmias in the younger kids. What sports does it happen in? Anything that has a projectile object. A lot of our sports, in anything that has a collision with another player. Okay. Again, there is no pre-participation screening that you can do for it, but this is more awareness. And it was very funny. Just this morning, I got an AAP news that said the most, I know my phone, yes, the sudden cardiac arrest symptoms in young athletes. And they were talking about AEDs, that we need to make sure they're available at all the athletic fields and schools, because the survival rate is very, very low. Survival rate is low. So it is more awareness is what we need with this particular lesion. Okay, so again, if you guys have any questions, please pitch in. So when they come to me, so what do I do? Again, we go through the history and the physical, but pretty much every kid who comes to me, either it's not in any order, any of these evaluations, they pretty much get EKGs. EKGs is helpful in a lot of different things, and I'll show you some EKGs. Chest X-ray, we don't do chest X-rays anymore. And again, all Holter monitors, echo, tilt table tests, and genetic testing. I mean, these are all the things that we have available to try and make sure that these kids are more, are safe to go back to physical activity. EKG, it is not part of our pre-participation physical at this point. And over the last 26 years that I've been in cardiology, we always go back and forth. Should we do it? Should we not do it? Italy is doing it, and some other countries are doing it, but US has a huge, big population, huge number of kids, and there's tons of false positive, and there's a lot of different reasons which it is not recommended at this point, but it is important. EKG is indicated in any kid who passes out. So a lot of different things that we can pick up by EKG. So there are a lot of things, and I'll be happy to look at any EKG that you can fax to me. So hypertrophic cardiomyopathy, long QT, WPW, and the list goes on. And I have had kids come in with, pre-syncope while ballet dancing, and she had primary pulmonary artery hypertension. I mean, it is there. And we had another kid come in with complete heart block and transposition of the great arteries, the different type, LTGA, when she was a teenager. So EKG, yes, it is helpful. EKG is needed. So again, like I was telling you earlier, when we talk to kids, oh yes, all these teenagers come in with, I felt faint, I lightheaded, and blurring of vision and all that. And it's like, yes, it could be our most common cause, the neurocardiogenic syncope, vagal faint, and this is typically what it is. You put them on a tilt table test, and they go asystolic or bradycardic. And actually, this is just a common faint. And this kid went back to sports and was completely normal, no problems with it. But this is a normal neurocardiogenic syncope. So genetic testing, that sort of came out with our first, with our case that we presented. A lot of the cardiac causes for sudden death are genetically inherited. So once again, I sort of keep going back to this, and we have a long QT syndrome. We know what genes are. Is it sodium channel, potassium channel? We know how to treat them. Brugada syndrome, ARVD, Marfan's, Ehlers-Danlos. I mean, we keep seeing all those in genetic testing, and it is not a research tool anymore. It is clinically indicated. Yes, we have trouble trying to get it approved, but it is possible to get genetic testing. So couple cases, if you guys have any questions in between, please let me know. This was one of the cases that came, again, a teenager, male, 17-year-old. He's been playing football all his life. He's a weightlifting and football, and it seems to be a very and tattoos. Yes, how can I forget tattoos? It's such an in thing now. So he was completely asymptomatic with tattoos all over his body, asymptomatic, protein supplements. So his PCP, all these cases are the ones that came to me from PCP. It's referred for a heart murmur and an abnormal EKG. Of course, family history is unknown. It's like goes from one foster family to the other, but very, very sweet kid, very well built, very muscular, no dysmorphic features. This is again very funny. Since I have genetics with me, it's always so interesting. And anytime I have a funny looking kid, I go call Dr. Hajanpour, can you put your eyes on this kid and see what you think about it? And then my son was there a couple of weeks ago. I didn't tell him it was my son. I took him there and said, Dr. Hajanpour, what do you see wrong with this kid? He said, okay, why is he so tall? Open your mouth and let me see your wingspan. And then he said, maybe he looks funny like his mom. And he said, Dr. Hajanpour, I'm his mom. So, but anyway, and then he sort of said, have you done an echo on him? I said, no, I have not done an echo on him. Maybe I should. But anyway, very well built, muscular, normal general exam, bradycardic. Again, keep this in mind, bradycardic, a little hypertensive. He has a non-specific systolic ejection movement, okay? And I'm going to show you his EKG. EKG is abnormal with increased voltage criteria for left ventricular hypertrophy groups. And again, his echo was also abnormal, but it is not the typical echo for hypertrophic cardiomyopathy. His septum and posterior wall, can that go away? Or that white black bar at the bottom? No? Okay. Anyway, so the heart was normal. The heart was thick, but the septum and posterior wall had the same measurements, and his heart was big. Remember, I told you hypertrophic cardiomyopathy, they have small hearts. Oh, thank you, Brian. But this is a kid who is played football all his life, has a nice normal heart, structured heart. Okay, I guess we can't take it out. Oh, good. So this is his EKG. And again, remember, I tell all the students, make sure you look at the standardization for picture here, because these voltages are twice than what you see here. He has significant left ventricular hypertrophy by voltage criteria, but this is a normal EKG for him. Why is it a normal EKG? He's a kid which we call it as athlete's heart. Athlete's heart has its own ICD code. This is the normal cardiac adaptation in a kid who does significant amount of high intensity sports. They are bradycardic, they have heart murmurs, they have some type of first or second degree heart block. Yes, their echoes are, their hearts are big, dilated, but they have symmetric thickness of all the walls of the heart, very different from hypertrophic cardiomyopathy. But sometimes when it sort of goes, the hypertrophic cardiomyopathy, athlete's heart are sort of, what should I say, hard to distinguish. We have to ask these kids not to participate in sports at least for 3 to 6 months to see if the hypertrophy resolves. And no kid is going to tell me that I'm going to stop playing sports. So maybe genetic testing in all these kids will be useful in the future.
And you mentioned blood pressure in him was a little bit
Yes,
elevated.
yes. So
Does that
what
have anything to do with?
So why is the blood pressure elevated? So these kids are bradycardic, right? So they have increased vagal tone, their heart rates are low. So when their heart rate is low, they have more diastolic filling time. So when they squeeze, when the heart squeezes, their stroke volume is up. So their systolic blood pressure is high. That is normal for them.
And is it the same with the hypertrophic kids?
No,
too?
the hypertrophic cardiomyopathies have low blood pressure. Their cavities, hypertrophic cardiomyopathy, the cavity is small. The athlete's heart, they have big hearts. So those are all the normal things that we see in a very physically active teenager. So that little bit of bradycardia, the hypertension is all normal in them. Like completely normal, and then that EKG was normal for him. So couple more cases that I have, and this is a one that comes again from our primary care physician. They found this by physical examination. So So right after S1, listen to see if there is any abnormal sound. So that clicking of the bicuspid aortic valve. So once again, family history pretty much unremarkable. Exam, the only finding that we hear is the ejection click. He's 13 years old, never found before because no stenosis, no regurg, so no coarctation, so nobody found it because it's not easy to hear that click. EKG is normal. He has a nice bicuspid aortic valve. That's the pictures that I was showing you before. So when we have these kids, so what are we going to do? Are we going to let them go into sports? So again, like I was telling you, we have Bethesda guidelines. We call it Bethesda because the American Heart House was in Bethesda, Maryland when all these guidelines came about, but now they've moved to Washington, D.C. But you can still Google Bethesda guidelines and you can get it. So this is a kid whose aorta was so dilated, 45 millimeters, 4.5 centimeters. He can only participate in low intensity competitive sports class 1. So what do you mean by that? So what do we mean by that? This is how we classify sports, and I have taken this into my exercise restriction forms for kids, and I'll show it to you. So these are the sports. It is labeled, we know which sports they can play, so I can sort of check off on the ones that they can play or check off the ones that they cannot play. So this is the sports classification. And every 10 years, these guidelines get updated because when you look at it, yoga wasn't there 10 years ago. Yoga got into our sports and cricket wasn't there. Cricket got into our sport. Of course, you have football and all those decathlon and tennis, everything is there, but this is new. These guidelines came out in 2015, so every 10 years we keep getting updated guidelines. But it's a fun piece of guidelines that we have to go with. So what I was telling you was, so when I send my restriction forms to schools, and this is the time that everybody wants it in their school, nurses want it, the parents want it. So what I do is I sort of put this into my restriction form, and then I can check and see what sports they can play, what they shouldn't play. And so we have much clearer information to give them. My last case, again, a 15-year-old basketball player. He was already so anxious, saying that you cannot make me stop play basketball. So I was already sort of getting a little tons of pressure from him. Yes, my maternal aunt had some palpitations. Exam again, pretty much completely normal, but look at the EKG. So EKG does tell. So what does the EKG tell us? 15-year-old, he's in the office. He's had no arrhythmias or no symptoms at this point. He has a delta wave. So that's that extra connection that you have between the upper and the lower chambers. And this kid, this EKG is abnormal. And yes, he is at risk for sudden cardiac death. That is the big thing. I know when I showed you all the causes, this is one of the rare causes, but yes, it's there. So we know he has WPW. This can give rise to ventricular fibrillation. There is no easy non-invasive test that we can do to see is this pathway malignant or not. So they all go into electrophysiology study and radiofrequency ablation. So once you get rid of your membrane, you're once again completely normal to go do whatever exercise you want. So this kid was back to his sports, back to playing basketball, and we felt fine that you can do what you want, and so we don't have to worry about him. So once again, that's sort of pretty much the cases that I had, and what I wanted to sort of emphasize is I know there's a lot of heart-related questions in your pre-participation physical. Yes, it's important. Health questions about the patient. Kawasaki has come in. Why do we want Kawasaki? Have you had Kawasaki before? Yes, we want to know because these kids are at risk for premature atherosclerotic disease, MI. So if you have an MI in a young adult, did you have Kawasaki as a young kid? We need to know. Again, we went over the heart health questions about the family, how important it is, and a couple of things that I wanted to bring out was SID, sudden infant death syndrome. sudden or single car accidents. What do we mean by single car accidents? There was no collision there. The family member died, maybe long QT syndrome, arrhythmia at that point. So these are specific things. Yes, it's very important that we ask about, or we make sure that the parent looks at all these questions. Physical exam, for sure, it's very important. But at this point, I'm sort of going to stop there and basically again say we have a lot of kids that we screen. I know it's trying to find a needle in the haystack kind of a thing, but I found this long time ago. Even if one saves a single life, saves the whole world. So I don't know, but anyway, we are trying to find that one kid who is at risk. And a lot of things that I have seen reading through these guidelines, it doesn't mean that this is going to pick up all your cardiac causes. At least we have stuck to the guidelines. We have done everything. I always explain to the parents, it doesn't mean that you have come to me, I've done EKGs, echoes, that I have ruled out every possible cause. But at this point, this is what we can say. And at this point, we are going to let him go back to school.
And let's go ahead and open it up for questions or comments if anyone would like to add anything.
I have a question. The original case, the genotypically positive but phenotypically negative patient, what is the follow-up ongoing?
Yes. Did you have it in your slide? Yes.
Yes, so we did have it in the slide too. So typically with these kids at this age, starting at 12, we'll want to do an echo every single year to make sure that they haven't converted to the hypertrophic cardiomyopathy. Can you hear that? And then up until they're about 18 years old, 18 to 20, and then they can start doing every 5 years to see if they have conversion or not. I think there's a slide on there too.
And echo is fine, you don't need an MRI?
Not at this point. Again, we don't do another MRI. We initially did that just to help with the risk stratification because that is more specific, sensitive than the echo, but not necessarily MRI all the time. Yes, that's correct.
I have a question.
Yes.
Can you hear me? This is Thomas Gill. Does bradycardia in an athlete rule out hypertrophic cardiomyopathy?
No, not necessarily. No, it doesn't. Bradycardia could be just normal sinus bradycardia, which again, like I said, part of the athlete's heart. Sinus bradycardia always worry about long QT syndrome. So when you have a bradycardic kid, make sure you look at the QTC interval. But no, it doesn't necessarily rule out hypertrophic cardiomyopathy.
Any other thoughts or questions? That was a great review. Thank you. It always makes me nervous being the screener pediatrician and knowing that it is like finding a needle in a haystack. And as I always tell my residents and students, I think the history component is just as important and perhaps even more important than the actual physical exam, considering very few of these have a physical exam finding that we can even pick up on. And so just remembering that, particularly as you are going through all of these pre-participation sports physicals here with football season and soccer season that are right here with us. Thank you all so much for your participation. It's great to see everyone. We will do this again next month. We're going to be talking about congenital heart disease. So if you have some patients that you have some questions about, please log on to the CME website at ETSU, and we'll have some case presentation forms there that you can submit your questions to Dr. Anna. She'll review those and cover some of those topics during our next session. Thank you all. If you want to get CME credit for this afternoon, fill out your evaluation form that is also in the email and a link on the CME website, and you will get an hour of CME credit. Thanks to everyone for joining us. We'll see you next month.
Thank you.
Thank you very much.
I know they turn, sometimes they can turn off the
They turn off the
video
camera.
While they're eating lunch.
Yeah.
So how many people logged in today?
9?
Huh?
9?
9.
But we only saw like 4.
So some of them, if you don't have a camera on,
You can do by phone.
you can do by phone. Some people will
Turn
just
off
have
the
a
camera.
blank, turn off the camera. But yeah,
Not bad.
it's pretty good.
Not bad.